Why are we still confused about how to use the HINTS exam? No nystagmus, no HINTS exam for you! 8 years ago, in my first vertigo approach video that I made for YouTube, I came up with this soup Nazi meme about the fact that you shouldn't do the HINTS exam on patients who don't have nystagmus at rest. Hi, Peter Johns here. Despite the fact that the HINTS exam came out in 2009, there's still some misunderstanding as to who exactly emergency physicians should be doing the HINTS exam on. In this video, I'll do a deep dive into how this misunderstanding may have come about and try and clear it up so that you can do the HINTS exam on the right patient the right way. In particular, I'm going to look at what's the role of the neuro exam in patients with constant dizziness. How do you use the HINTS exam to send a constantly dizzy patient home without imaging? Should we use HINTS in patients without nystagmus? And if not, what do we do with those patients with constant dizziness who don't have nystagmus? I've practiced emergency medicine for 37 years. Having taught others for vertigo for over 20 years, I know that the fear of missing a stroke presenting with dizziness vertigo is a significant concern for us. To miss a stroke, which might lead to a bad outcome for the patient and possible medical legal consequences, weighs heavily on us when we see dizzy patients. And I'm a firm believer that the HINTS exam, when performed on the right patient the right way, is very helpful in helping emergency physicians to determine which dizzy patients can be discharged safely home without a concern for a dizzy stroke. Because by using HINTS and definitively diagnosing a non-dangerous peripheral cause, vestibular neuritis, you effectively rule out any central or dangerous causes like a stroke. And there are two key points that I've tried to make very clear about using HINTS, and they are that you should first screen your patients for central features that would not be expected to be found in patients with vestibular neuritis but could indicate a stroke, and that you should only use HINTS on patients with nystagmus at rest. And I kept stressing these points in all my subsequent publications. In my CMAJ article, where I made them key points, and in my CGEM article, Just the Facts, I also recommended screening for central features and to only do HINTS on patients with nystagmus. And also in the vertigo chapter in Tintinelli's Textbook of Emergency Medicine, where the central part of my algorithm screens for central features and you had to see nystagmus at rest to progress onto the HINTS exam. Let's address the first question. So what's the role of looking for neurologic findings in patients with dizziness? Patients with constant, persistent dizziness are certainly at risk for having a stroke, although benign causes are more common. And in patients where you're worried about missing a stroke, you should ask about stroke signs and symptoms. I call these the central features: focal weakness or paresthesias, and the posterior circulation stroke symptoms, the so-called dangerous Ds, diplopia, dysarthria, dysmetria, dysphonia, dysphagia. Vertical nystagmus at rest, like this, is very concerning for a central cause. But remember that during the Dix-Hallpike test, vertical upward nystagmus with a torsional component towards the downward ear is not a central finding, and in fact is the typical nystagmus seen in posterior canal BPPV. And the last two central features: if your patient normally walks without any problem and now can't walk unassisted, that's concerning for a stroke. And lastly, a new significant headache or neck pain. This would make you think about a cerebellar hemorrhage or vertebral artery dissection. Patients with non-dangerous causes of vertigo have no business having any of these central features, either at the time you're seeing them or if they report that they had any of these features earlier in their dizzy spell. And unfortunately, some dizzy strokes won't have any of these central features. Yes, it is true that these neurologic signs are not sensitive enough to rule out a dizzy stroke, as shown in this recent systemic review and meta-analysis about the diagnostic accuracy of the physical exam in vertigo. So you can't rely on these central features to identify all dizzy strokes. But the specificity is pretty high, 92%, which means that if you see any of these central features, you should be very concerned about a dizzy stroke. And in another systemic review by Tarnutzer, it shows that an abnormal neurologic exam had a high positive likelihood ratio to rule in a stroke. The only thing that ruled in a stroke with a higher positive likelihood ratio was an abnormal MRI. And in the same table, it shows that finding an overall HINTS exam that was peripheral had a high negative likelihood ratio, so very good at ruling out a stroke. And this is why the HINTS exam is so useful for emergency docs. Because as I said, definitively ruling in vestibular neuritis rules out a stroke. Keep in mind that the HINTS exam studies blinded the examiners to the general neurologic exam in order to determine the diagnostic accuracy of the HINTS exam on its own. Luckily, in clinical practice, we're not blinded to the neurologic exam, so we can screen our dizzy patients for central features, and if we find any, we know that those patients are at very high risk for having a dizzy stroke. Those with constant dizziness and nystagmus at rest who screen negative for central features, that's who you do the HINTS exam on, to confirm the suspected diagnosis of vestibular neuritis. Vertigo experts know this and consider it an obvious step before applying the HINTS exam. In fact, a neurologist and vertigo expert just wrote to me to say that identifying central features is, and I quote, almost implicit to me. But the level of understanding in ED docs and other frontline providers in the assessment of dizzy patients is generally not very good. So this obvious, important step needs to be stated in an obvious and forceful manner in order to prevent us from missing dizzy strokes. Because if people with limited knowledge of vertigo don't get the message about the obvious things, the subtle things don't matter much. I've seen a dizzy patient who told the triage nurse that they had had slurred speech and tingling in one arm early in their dizzy episode, and the emergency physician didn't mention this at all in their history and diagnosed them with a benign condition and sent them home. And a few days later, I saw them and was able to diagnose their dizzy stroke. So is this message getting out forcefully and clearly to screen our dizzy patients for central features? Unfortunately, not so much. In May 2023, Academic Emergency Medicine published the GRACE 3 document, which made 15 recommendations about the assessment and care of acute dizziness and vertigo patients in the emergency department. There were 19 authors, some of whom are emergency physicians, including Jonathan Edlow, who is the first author. Others are neurologists with subspecialty training in vertigo. All the authors are very vertigo-interested clinicians who want to help us and our patients benefit from proper vertigo assessment. GRACE 3 is a hefty document, 38 pages long, and has 266 references. There's a link to it in the video description below. I agree with almost all the 15 recommendations. For instance, the first one is that we need to train emergency physicians in the bedside diagnosis techniques of the Dix-Hallpike test and the HINTS exam. I'm certainly all for that. The second recommendation is that we should use the HINTS exam in patients with acute vestibular syndrome and nystagmus to determine if the cause is a central one or a peripheral one. Again, no big concern here, except what do they mean by acute vestibular syndrome patients with nystagmus? But more on that later. And why didn't they include screening for central features to help identify strokes presenting as the acute vestibular syndrome? The way it's written, you might think that the HINTS exam is the only thing you need to do to avoid missing a dizzy stroke. There is a short statement inconspicuously placed on page 4, indicated by the blue arrow. Here it is blown up. A few words saying that patients with obvious stroke symptoms like hemiplegia or visual field defects or altered mental status are not the patients we should be applying HINTS to. But I don't think patients with these overt symptoms are the dizzy strokes that are being missed. It's the ones with more subtle symptoms like the central features I just told you about. So unfortunately, the GRACE 3 recommendations make no clear statement about looking for central features in these patients at high risk for a dizzy stroke. Does the accompanying diagnostic algorithm on page 12 of the GRACE 3 document help clear it up? There's just a statement to again look for obvious neurologic findings, and if so, call a stroke code. And if not, pretty much go straight to the HINTS exam. What about other educational resources for emergency physicians? The 10th edition of Rosen's Textbook of Emergency Medicine has an algorithm that states if you have persistent symptoms, you go straight to the 3 components of the HINTS exam. Then look for neuro findings after that, which I think is a backwards approach. You should screen for central features first, then apply HINTS. So the answer to how important it is to look for central features to help rule out a stroke? Very important. And why are we confused about this? Because trusted sources of information haven't made it clear and obvious to emergency physicians that we can and should look for them. You may have noticed that neither of these algorithms stated that you must see nystagmus at rest in order to apply the HINTS exam. In fact, they both lead you to perform the 3 components of the HINTS exam on any patient who says they have continuous dizziness or persistent symptoms, whether or not they have nystagmus. So clearly no hard stop to prevent emergency doctors from performing Hintz exam on patients without nystagmus. And guess who needs and uses these algorithms? Not the vertigo experts. Their algorithms are well embedded in their brain. It's the frontline clinicians who need to be led clearly and unwaveringly to the right diagnosis. And I suggest that these algorithms don't specifically instruct them to look for central features and to not perform the Hintz exam on patients without nystagmus. And this will cause them to miss some dizzy strokes and be needlessly concerned about stroke in other patients who aren't having one. So let's look carefully at the Hintz exam and answer the next two questions. How can we use the Hintz exam to send home some patients without imaging? And is there any reason to perform the Hintz exam on patients who don't have nystagmus? And to answer that, we need to go back to exactly what is the acute vestibular syndrome and how does the Hintz exam help us when we see these patients. The acute vestibular syndrome, AVS, was defined by Hodson and Balow in 1998. It's an acute onset of vertigo, nausea and vomiting, postural instability, which means difficulty walking, standing, or even sitting, and spontaneous nystagmus. At this point, I should let you know that not everyone agrees to use the original strict definition of AVS by Hodson and Balow. For instance, in 2018, Lugren defined AVS as being ongoing dizziness with two or more of the following symptoms: nystagmus, nausea, vomiting, gait problems, or worse with head movement. And NAM used a very permissive definition of acute vestibular syndrome as a day or more of spontaneous, abrupt, continuous onset vertigo, dizziness, or unsteadiness. That's it. No other qualification. Which means that patients could be defined as having AVS when experiencing a day of persistent dizziness only. No need for nystagmus, or nausea or vomiting, or worse with head movement, or difficulty walking. I have a lot of issues with this definition, as we'll discuss later. And I just learned that the ICD-11 has a definition which is very similar to that used by NAM. It mentions nausea, vomiting, nystagmus, and postural instability, but does not mandate them for the definition. So the same concern that anyone who says they're dizzy can be defined as acute vestibular syndrome. And it turns out that's what the GRACE 3 paper uses as their definition for the acute vestibular syndrome. But let's get back to the strict definition by Hodson and Balow, which is the one I teach, and that mandates that the patient must have spontaneous nystagmus to be acute vestibular syndrome. Spontaneous nystagmus is the nystagmus seen with the patient at rest and looking straight ahead, as in this patient. The basic differential diagnosis of these patients is this vestibular neuritis, which is more common, or is this a posterior circulation stroke, which is less common? In fact, Jonathan Edlow said this in his 2019 paper. Any data to back this up? Remember that meta-analysis by Tarnutzer of studies reporting the diagnostic accuracy of Hintz in the acute vestibular syndrome? The only peripheral etiologies that were identified by the Hintz exam in their meta-analysis were 377 cases of vestibular neuritis and 1 case of labyrinthitis. That's it. No other cause of peripheral vertigo were found in all of the Hintz studies. So when Hintz is used appropriately in patients with constant dizziness and nystagmus at rest, the only peripheral diagnosis it makes is vestibular neuritis. And it's a very important one to make because, as we said, if you can definitively diagnose vestibular neuritis, you can rule out a stroke. Here's another systemic review and meta-analysis with Tarnutzer as a senior author, this time looking at the diagnostic accuracy of spontaneous nystagmus in the acute vestibular syndrome. They found that 98% of the peripheral causes of acute vestibular syndrome had spontaneous nystagmus. They also found that 96% of the peripheral causes were either vestibular neuritis or labyrinthitis. The spontaneous nystagmus in vestibular neuritis lasted an average of 3 to 4 days. So, virtually all the people with the acute vestibular syndrome from a peripheral cause has vestibular neuritis or labyrinthitis, and virtually all patients with vestibular neuritis have spontaneous nystagmus in the first 3 or 4 days. That would seem to have a significant impact on the usefulness of Hintz in patients who don't have nystagmus at rest. But before we get to that, let's first look closely at how and why the 3 components of the Hintz exam reliably identifies vestibular neuritis in patients with constant dizziness and nystagmus. I'm listing them in the order that you should perform these tests. The first 2 components of the Hintz exam look for findings that are only seen in stroke and not in vestibular neuritis. And they are nystagmus that changes direction with gaze, as seen here, beats to the left when she looks left, and when she looks to the right, it changes direction, beats to the right. Any patient with constant dizziness and nystagmus that changes direction with gaze is having a central cause for their vertigo, mostly stroke. The second Hintz finding that is only seen in stroke is abnormal vertical or diagonal skew. When his right eye is uncovered, the eye moves diagonally upward and inward and downward and inward for the left eye. Neither of these findings are seen in most dizzy strokes, but if you do see them, it's a stroke. And you don't see these findings in vestibular neuritis. Now contrast that to the head impulse test. It's looking for a catch-up saccade which is seen when the head is turned rapidly in the opposite direction of the nystagmus. It should always be seen in patients with vestibular neuritis, which is the only peripheral cause of vertigo in patients with constant dizziness and nystagmus, and rarely in stroke. And it looks like this.
Well, there it is.
And another example, beating to the left when she looks left, and when she looks to the right, it's still beating towards the left, although it's less. And when her head is turned rapidly to the left, right there, it's normal. And when he's turned to the right, catch-up saccade right there. Entirely consistent with a right vestibular neuritis. As we saw, for the first 3 or 4 days of their illness, virtually every patient with vestibular neuritis has nystagmus at rest, which doesn't change direction with gaze, as we just saw. In fact, Edlow says if you don't see nystagmus, you've essentially ruled out vestibular neuritis, and virtually all of them have an abnormal head impulse test. At this point, I'll bring in the recommendation 3 of the Grace 3 paper, which says you should use the finger rub test to detect a new hearing loss in patients with acute vestibular syndrome. This is the plus part of Hintz Plus, and it's used to pick up an ICA stroke, anterior inferior cerebellar artery stroke, because in this kind of cerebellar stroke, the whole labyrinth is infarcted, which can give you the same Hintz result as in a vestibular neuritis, but the cochlea is also infarcted, so the patient has a new hearing loss. So that's how you can save yourself from missing an ICA stroke, by looking for a new hearing loss in patients with constant vertigo and nystagmus, by adding the bedside test of hearing. Now that we've gone through all of this, we can answer question 2 of how you can use the Hintz exam to safely send home a patient without imaging. They must screen negative for central features, you can't see direction-changing nystagmus or skew deviation, and you must see nystagmus that doesn't change direction with gaze, and an abnormal head impulse test. That's why the head impulse test is the most important part of the Hintz exam. If you don't see an abnormal catch-up saccade when their head is turned rapidly in the opposite direction of the nystagmus, then you can't send them home as vestibular neuritis. This is a very important point. So I'm going to repeat that in the positive form. You must see an abnormal head impulse test if you're going to send somebody home with a diagnosis of vestibular neuritis. And just as discussed, they also shouldn't have a new hearing loss. Now what about question 3? What happens if you apply Hintz to patients who complain of constant or persistent dizziness but have no nystagmus at rest? Is there any benefit to it? Is there any harm? Let's start by seeing if there's any usefulness to applying Hintz in patients without nystagmus. The whole point of Hintz is to find out whether your patient with constant dizziness has a central cause for their dizziness or a peripheral cause. And we've seen that the only peripheral disorders identified in all the Hintz studies is vestibular neuritis and a rare case of labyrinthitis. We've also seen that patients with vestibular neuritis almost always have nystagmus at rest for the first 3 or 4 days. That means if you were to decide to perform the Hintz exam in a patient population without nystagmus at rest, you've already removed virtually all the patients that can be identified as having a peripheral Hintz result. So Hintz can't identify any peripheral causes in this patient population. A test on a patient population that can only lead to one result, in this case a Hintz central result, has no value. So there's no benefit to performing Hintz on patients who don't have nystagmus at rest. And if there's no benefit to a test in a particular patient population, I can't see why you'd even contemplate it. Now, have others suggested that doing Hintz in patients without nystagmus may not be a good idea? Again, Edlow, this time in the Grace 3 paper, correctly states in Table 4 that the head impulse test has only been validated in patients with nystagmus. And we've already explained how the head impulse test is the most important part of the Hintz exam. Here's another way to convince you that the Hintz exam is of no use in patients without nystagmus at rest. The HINTS exam is the head impulse test, nystagmus, and test of skew. And we just said that the head impulse test is unreliable in patients without nystagmus. And just to be clear, there's no nystagmus in patients without nystagmus, so that can't be useful. And what about the test of skew? I asked Jorge Cata, lead author and principal examiner of patients in the HINTS studies, and he said it's very rare to have patients with an abnormal skew who don't have nystagmus. So every single component of the HINTS exam is either eliminated or compromised when applying them to patients without nystagmus. And lastly, if you still think there's value in doing HINTS in patients without nystagmus, please explain to me what would be the diagnosis in a patient without nystagmus where you did the HINTS exam, you find an abnormal head impulse test, which you must see in order to have an overall HINTS peripheral result, and then could say to yourself, well, it sure is good that we did the HINTS exam. Now we know our patient has a peripheral disorder. There may be some rare diagnoses like bilateral vestibular hypofunction, but they are quite rare and they're not something that we need to identify in the emergency department. I've had some people argue that HINTS will still pick up strokes in those with constant dizziness and no nystagmus. Well, of course it will. All the patients will have a central result, and a test that only has one result is the worst kind of test. You could use the presence of a pulse as a test for central vertigo in these patients instead, because having a pulse can't identify any peripheral cause of vertigo either, but it will be 100% sensitive for finding the strokes. Now that we've shown that there's no benefit to performing HINTS in patients without nystagmus, is there any potential for harm? What's the harm if you perform the HINTS exam on a patient with BPPV, for instance? BPPV is the most common cause of vertigo that emergency physicians see. And as stated by Edlow and Kerber in this paper, many patients with BPPV complain of a milder baseline constant dizziness. So if patients with BPPV who have no nystagmus at rest but can often complain of mild baseline constant dizziness were put through the Grace 3 or Rosen's algorithm, they would have the HINTS exam applied to them. Their head impulse test would be normal, and guess what? That's an automatic HINTS central result, which would lead to unwarranted concern for stroke and unnecessary MRIs, instead of the Epley maneuver, which is what they actually need. And this is exactly what is stated in Grace 3 in Figure 3. It's also buried in a wall of text on page 18 of the 38 pages of the Grace document. So what do the Grace 3 recommendations actually have to say about doing HINTS exam in patients without nystagmus? In recommendation 4, they miss an opportunity to tell us directly whether or not to do the HINTS exam in this patient population. Instead, it states that in acute vestibular syndrome without nystagmus, you should use gait assessment to determine if the cause is central or peripheral. There's certainly value in assessing the gait in patients with constant dizziness but no nystagmus at rest. In fact, it may be the best thing to do for these patients. More on that later. But since we've already seen that patients with constant dizziness and no nystagmus don't have vestibular neuritis, why are they saying that vestibular neuritis is usually the peripheral diagnosis? Makes no sense. And let's face it, using a test that looks for a disease that isn't in your patient population isn't helpful. Thank you, Captain Obvious. And in recommendation 6 of the Grace 3 document, it gets even more confusing. It says in patients with acute vestibular syndrome with and without nystagmus, if a clinician trained in the use of HINTS is available, you don't have to do an MRI as the first-line test. You should do a physical exam first. What exactly are they trying to say here about patients without nystagmus? Why would you need a clinician who is trained in the use of HINTS exam to do a physical exam on a patient with acute vestibular syndrome who doesn't have nystagmus if they aren't going to do the HINTS exam? I can't explain this as anything other than indirectly saying that if you're thinking of getting an MRI on a patient with acute vestibular syndrome without nystagmus and you have a HINTS trained physician handy, have them do the HINTS exam to help you decide what to do. And that, I think, would be a very bad idea. Why? Just to recap once more, HINTS is really useful in patients with constant dizziness and nystagmus at rest, and we should be using it and be glad that there's a physical exam technique that we can sort out this difficult patient population. But on the other side of the coin is that in patients with constant dizziness with no nystagmus, HINTS is completely useless as there's no peripheral diagnosis that can be made with HINTS in these patients. So going back to what I think are flawed algorithms, what's going to happen when vertigo novices follow the Grace 3 or Rosen algorithm? They're going to ask their patients without nystagmus, are you still dizzy? And when some BPPV patients or vestibular migraine patients say, yes, I still am kind of dizzy, they'll do the Hintz exam on these patients, see a normal head impulse test, which is what you see in BPPV patients as well as vestibular migraine patients, which leads to a falsely positive Hintz central result, and off the patient goes for a useless MRI. Now, is there any literature to support my concerns that we aren't performing the Hintz exam in the right patient population? Well, yes, there is. First, a study by Robert Ole from Sudbury, Canada, showed that the Hintz exam was done on about 20% of their dizzy patients, but that in 97% of the time, they were the wrong patients. That is, they either didn't have constant dizziness or they didn't have nystagmus at rest. This fact didn't escape the Grade 3 authors who, in the abstract, noted that we are applying Hintz in the wrong patients. And to quote, "It is clear that in 2023, when applied in routine practice by emergency clinicians without special training, Hintz testing is inaccurate, partly due to use in the wrong patients and partly due to issues with its interpretation." Too bad the 15 recommendations in Grade 3 never stated who are the wrong patients to use the Hintz exam on. And in case you weren't paying attention, that's patients without nystagmus at rest. Another example of what happens when you apply the Hintz exam to patients without nystagmus at rest shows up in Gurlier's study, where emergency physicians were trained in bedside testing of patients who had persistent dizziness, either with or without nystagmus. They excluded patients who had no symptoms at the time of the examination. You would think that would exclude the majority of BPPV patients. Well, in fact, out of the 300 total patients that were entered in that study, the most common diagnosis by far was BPPV. And Gurlier noted that the false positive Hintz exams that occurred in her study were mainly in BPPV patients. So by applying the Hintz exam to patients without nystagmus, it only created unwarranted concern for stroke in patients with BPPV. And I think that's pretty significant harm. And the same thing can happen to patients with vestibular migraine. It's actually a very common cause of dizziness, but way underdiagnosed. Emergency docs, by and large, aren't even aware that it exists, and certainly very few know how to make the diagnosis. You can see my video on vestibular migraine to explain it in more detail. I'll put a link in the video description. Vestibular migraine patients can also present complaining of constant dizziness, have no nystagmus, and will have a normal head impulse test, which will again lead to a Hintz central result, and to unwarranted concern for a stroke. Any studies to back this statement up? Remember earlier when I talked about alternate definitions of acute vestibular syndrome, and I said that NAM had a definition which all you had to do was say you were dizzy for a day and you didn't have to have any other symptoms and you were called the acute vestibular syndrome? Well, in this study, where they used their loose definition, it resulted in finding that 11% of their acute vestibular syndrome patients were actually suffering from vestibular migraine, almost all of which had no nystagmus and a Hintz central result, a false positive. Again, showing that applying Hintz exam to patients without nystagmus can lead to the harm of unwarranted concern about stroke. So the answer to the third question, if we should do the Hintz exam on patients without nystagmus at rest, is a resounding no, that it will not identify any peripheral diagnoses and will only harm by falsely raising concerns for stroke in patients who don't have a stroke. Which leads to our fourth and final question, which is one I know many of you are very keen to know the answer to. So what do you do with patients with constant dizziness but no nystagmus at rest? First thing is to look very carefully for nystagmus. After a day or two, the nystagmus in vestibular neuritis may only be visible if you ask them to look 30 degrees off center and remove fixation somehow, because in peripheral cause of vertigo, visual fixation can suppress nystagmus to the point where you might miss it. I suggest you use a blank piece of paper placed beside their head. I made a video that shows you a good example of how I used this to find the nystagmus in a case of vestibular neuritis, which my colleagues had missed. Again, there'll be a link in the video description. Now, if they truly have no nystagmus in the first several days, as we've seen, they don't have vestibular neuritis. But can a patient with constant dizziness but without nystagmus at rest be having a stroke? In fact, yes, very much so. If we circle back to the statement by Edlow that said if you don't see nystagmus in a patient with persistent dizziness, you've ruled out vestibular neuritis, well, the words following that state that a posterior circulation stroke is still on the differential. In fact, in NAM's study, he found that 44% of posterior circulation strokes did not have spontaneous nystagmus. That sounds pretty concerning. At this point, you might be thinking, well, why not do the HINTS exam on them? Find the dizzy strokes. But once again, HINTS can't find any peripheral diagnoses of dizziness in that patient population because patients without nystagmus don't have vestibular neuritis, and therefore they won't have an abnormal head impulse test. And all of these patients will therefore have a normal head impulse test and a false positive HINTS central result. And checking for a pulse will be just as useful to identifying dizzy strokes as the HINTS exam would be. Remember what Captain Obvious said, that using a test that looks for a disease that isn't in a patient population you're testing is not helpful, and as we've seen, can cause harm by raising unwarranted concern for stroke in patients who aren't having a stroke. We're so close to the finish now. We've established that looking for neurosigns and symptoms is important, and that HINTS can reliably identify vestibular neuritis and thus rule out a stroke in patients with constant dizziness and nystagmus at rest, but that HINTS can only cause harm in patients without nystagmus at rest, and that patients who are still dizzy and have no nystagmus can be having a stroke. Is there any way we can maybe sort out who we need to worry about in those patients with constant dizziness but no nystagmus at rest? Remember in GRACE 3, the fourth recommendation said that in patients in acute vestibular syndrome without nystagmus, they suggested assessing the severity of gait instability to figure it out. And I said there was value in this. I think there's a lot of value in this. Let's have a look at a paper that shed some light on it. Machner reviewed patients who were admitted to the neurology service with dizziness, vertigo, or imbalance with an uncertain diagnosis. In his paper, he defined a new syndrome which he called the acute imbalance syndrome. These were patients who had persistent dizziness, no nystagmus, but had an acute onset of unsteadiness in their ability to stand or walk. I confirmed via email with Bjorn Machner that in fact the changes were objective findings and not just a patient complaint. And it turns out that 33% of these patients had an abnormality seen on delayed MRIs which explained their problem, and most of them had strokes. For those patients who had high risk factors for stroke using the ABCD2 score, 50% had abnormal MRIs. So you should be very worried about patients who are dizzy, have no nystagmus, but have an objective new difficulty walking. And this makes sense because if a patient with recovering vestibular neuritis and you couldn't see nystagmus even when looking carefully 30 degrees off center with fixation removed, their gait should have recovered enough so that you wouldn't see an objective change in their ability to walk unaided. How might this play out? Well, imagine seeing two patients in your emergency department, both with constant dizziness lasting many hours and difficulty walking, and that they both screen negative for central features. Now I'll let you know that one has vestibular neuritis and the other has a stroke. Let's have a look at their gait and see if you can tell which one more likely has a stroke. Patient 1, well, he looked turning a little funny there, walking almost like he could be drunk, but he's not. And tandem gait, well, misstep there. Another one to the left, not doing that great. And now one off to the right. Well, that's not very good tandem gait. Okay, this guy also kind of walking not very sure of himself there. Turn around, he falls over a bit. Let's see his tandem gait. Not bad, but he fell over a little bit. Okay, well, let's see you do a Romberg. Yeah, feet together. Yeah, put your arms out in front of you. Now put your hands right close together there. Now close your eyes, and, well, pretty darn good. So which one's more likely to be having a stroke? Frankly, at this point, we don't know. But let's say that patient 1 has horizontal nystagmus that is beating to the left, and patient 2 does not have nystagmus, even when he's asked to look through a blank piece of paper 30 degrees off to either side. Does this change the likelihood of who is having a stroke? Patient 1 could be having vestibular neuritis, which is more common than a dizzy stroke, especially when they've screened negative for central features. He'd be the perfect patient to do the HINTS exam on to definitively diagnose vestibular neuritis. But if patient 2 doesn't have nystagmus, he has the acute imbalance syndrome. He's still dizzy, has no nystagmus, and has an acute difficulty with gait, so he'd be at a high risk of having a dizzy stroke. He can't be having vestibular neuritis because all patients with vestibular neuritis have nystagmus at rest in the first few days. And since vestibular neuritis is off the differential, that leaves a whole lot of stroke risk. And in fact, patient 2 was having a stroke and was admitted, and patient 1 had vestibular neuritis and was sent home. At the beginning of this video, I acknowledged that the fear of missing a dizzy stroke weighs heavily on us. I know. Not long ago, I was asked to review a case of a patient who presented with dizziness, vomiting, and difficulty walking, but no nystagmus at rest, who was sent home as labyrinthitis and then returned a few days later as a very serious posterior circulation stroke. The clinicians who saw that patient obviously didn't know that all patients with labyrinthitis or vestibular neuritis have nystagmus in the first few days, or that patients who are dizzy have no nystagmus but have an objective new difficulty walking are at high risk of having a stroke. But now you know, and this new knowledge can save you and your patients a lot of grief. This leads us to one last patient presentation I'll talk about. Those who complain of constant dizziness, have screen negative for central features, have no nystagmus, and have no objective difficulty walking. These patients are probably at very low risk, but as far as I know, this population has not been studied specifically. Some of them may have BPPV or vestibular migraine, and these diagnoses should be considered. Some may be having other general medical causes like a UTI or hyponatremia or anemia. So to bring it all home, here's my suggested approach to help you not miss a dizzy stroke. First, screen all dizzy patients for central features. Those who screen positive should be worked up for stroke. If they have unequivocal neurological deficits beyond vertigo and nystagmus, initiate a stroke code. Next, in those patients with new persistent dizziness and nystagmus, in other words, the acute vestibular syndrome, apply the HINTS exam, adding the bedside test of hearing to catch the ICA strokes. To send a patient home with a diagnosis of vestibular neuritis, the patient can't have nystagmus that changes direction with gaze, or vertical skew, or have a new hearing loss. And you must see nystagmus that doesn't change direction with gaze, and an abnormal head impulse test when the head is turned in the opposite direction of the nystagmus. Anything else needs a stroke workup. If your dizzy patient has screen negative for central features and has persistent dizziness but no nystagmus even when you look carefully for it, but has a new objective change in their gait, then that is the acute imbalance syndrome, and they're at quite a high risk of stroke, and I would work them up for stroke also. Lastly, those who screen negative for central features, are persistently dizziness, have no nystagmus, and have no objective change in their gait, look carefully for BPPV and vestibular migraine or a general medical cause. If nothing is found, they can likely be discharged and follow up with a primary care physician. I know that Jonathan Edlow and all the other authors of GRACE 3 want to improve the quality of care that patients receive if they attend an emergency department. And they correctly identified training as an overarching recommendation of their paper, and that this training should be a priority for emergency medicine. I applaud them for their efforts, and I'm ready, willing, and able to assist them in this cause. But I also think I've shown that in the rush to embrace the useful tool which is the HINTS exam, there's been a de-emphasis on looking for neurosigns and symptoms which would allow us to identify a significant number of dizzy strokes. And that it's important to make it very clear in training materials and future algorithms that the HINTS exam should only be used in patients with nystagmus at rest. And lastly, that we need to be aware that patients with dizziness and new objective difficulty walking, but no nystagmus at rest, are at high risk of stroke. I sincerely hope that the educational materials developed to provide vertigo education to emergency physicians will take these concerns into account. Well, phew! That was quite the rant. The sad thing is that the HINTS exam is not the only thing that we're confused about. The proper assessment of BPPV, which is more common than vestibular neuritis and posterior circulation stroke combined, is often done poorly by emergency physicians. A topic for another video perhaps. Thanks for watching.